Hi, my name is Larissa Turin. I'm a care delivery supervisor and the clinic manager at Health Partners Midway Clinic and Center for International Health. And I'm here today with Karen Kramer, who is a Vice President of Disease and Case Management here at Health Partners. I was invited to come here today because Midway Clinic was part of the pilot for co-management workflow. You'll get additional information about this workflow in this care model process training. But basically we were looking at ways to improve communication between primary care and disease and case management and assure that care is smooth, that we have smooth handoffs and patients really see us as members of the larger Health Partners care team. So before we implemented the pilot at Midway, we had so many questions. I had a lot of questions, my providers and nurses did, and at times I felt like I was bombarding Karen with questions. So we thought it might be good for me to ask some of those questions today and have all of you hear the questions answered by Karen. I also wanted you to refer to your training documents. There's additional Q&A information in there. So Karen, can you tell us a little bit about what services case and disease management offers?
Sure. So our clinicians, who are primarily nurses and social workers, help patients and families with the health and care challenges that they face on a day-to-day basis. And we use a health advocacy approach, which is based on a one-to-one personalized relationship. So it's a continuous relationship. We don't use a call center model. And our team members have advanced skills and expertise in motivational interviewing, intrinsic coaching, shared decision making. And all those things enable them to help individuals gain more clarity about what they're wanting, what's important to them, helps them make better decisions that are based then on their values and preferences. And as a result of that, they're able to move forward then in working towards achieving their personal goals. And we help with connections to affordable and available resources that people have and need. And we help with communication and coordination across the full continuum of care. And we provide or promote self-sufficiency in individuals. So we want to make sure that they feel confident and competent in taking care of themselves and addressing whatever health and care needs they have.
How many people are in your department?
Well, we actually have a fairly large department. We have over 150 staff. Most of those are nurses and social workers who are providing direct help and support for patients and families. But we have support staff who are doing clerical functions. We have a small data and analytics team. And then we have a team, an interdisciplinary team of consultants that can help as well. And those include pharmacists, medical directors, certified diabetes educators, dietitians, mental health clinicians, those kinds of people. So we're working all together to provide the support that patients and families need. And then we also have a team of nurses who are dedicated to patients who are in the hospital and provide support for them to make sure that their stay is efficient, that they have a safe and timely transition to the next level of care that's appropriate for them, and follow up with them after they're home to make sure that they're safe, they're getting better, they followed through on the plan, so they have their appointments, their medications are set, those kinds of things.
Can you tell us if a patient needs to be a Health Partners member in order for us to refer to case and disease management? We have a lot of patients who have Medical, Blue Cross, other insurance carriers. What about those patients?
Well, you can refer those as well to us. So as long as the referral is coming from a provider or clinician in the Health Partners clinics, we're going to provide help and support for the patients even if they don't have Health Partners insurance. And when in doubt, go ahead and make a referral. We'll sort through all of that. If they have resources available through another insurer, we know about that. We'll make a connection to that and make sure all the resources that are available to them are brought to bear.
So basically for us in primary care, we don't even need to look at patient's insurance. If we feel that patient may benefit from disease and case management, we should just go ahead and make the referral.
Yes, absolutely.
Great. What about non-English speaking patient?
Go ahead and refer non-English speaking patients. It's helpful for us to know that obviously ahead of time. So we use interpreter services just like you do, and we also have a number of diverse staff that speak other languages as part of our team. So it may be that actually they will have clinicians supporting them that speaks their own language.
That's excellent.
Yeah.
How long do case and disease management care coordinators work with a patient?
Well, we're involved anywhere from 4 to 6 months up to a year. Some patients who are really complex, we just have a continuous relationship with, and that's ongoing. But for the most part, anywhere from 4 to 6 months to a year.
What is a typical interaction between a patient and a case manager?
Well, the interaction is very conversational, similar to what we're doing today. And we are going to do a lot of listening, actually. We get lots of feedback that it's very helpful, that people feel like someone's taking the time to listen to them, so we do a lot of that. And then we actually have a special way of asking questions in a way that elicits what's important, what they're wanting, to be able to help get towards what are priorities and what are needs, what are gaps. So it isn't necessarily going to feel like a real formal assessment, although that's what we're working into the conversation. We do communication over the phone. Some people like to communicate over email, so secure email is a way to sometimes communicate. But for the most part, people actually like the opportunity to have a conversation and to talk things over.
So you described a lot of the things that our RNs in primary care started to do. As you know, with our population health work, more and more, our RNs are working one-on-one with patients, helping them reach their healthcare goals. When should we think about referring patient to a case and disease management versus having clinic RN work with them as their care coordinator?
Well, first of all, we want both of the clinicians involved, so it's really not an either or, it would be a both and, because we want to make sure that that connection with the clinic is strong and solid, and so we wouldn't want you to think that you wouldn't have the RN care coordinator involved in the support. When things are really complex, there's multiple people involved, there's a lot of time that's needed to help support the patient, the family, when there's complex psychosocial needs, those kinds of things. That's generally when it's good to bring in an additional partner like us who we can help. We understand the breadth of resources, we have the time to do that extra coordination and the listening and the figuring things out. So it's generally when there's a more complex situation going on.
I also wanted to share with you that our clinic RNs found it helpful to refer some of the patients with really complex socioeconomic needs.
Yes.
And I think patients really benefited from your staff and their ability to actually go to their home or to meet with them at a place outside of the clinic and help somebody who is facing homelessness. Yeah. So we do have a number of patients that we do see out in their homes, or if they're homeless, so we may meet with them in Burger King or a park. I specifically know of a gentleman that our nurse Amy is routinely meeting in Burger King. That's their spot.
And he really likes Amy to come to clinic visits with him because she helps remember what the doctor's talking about, or things about medication that he's not remembering. And so they've built a nice, strong relationship. There's other patients in the Minnesota Senior Health Options product, or the coverage that they have. So they have Medicaid and Medicare. And we routinely see them in their homes, doing an assessment and visiting with them. And it's not uncommon that they might ask that their nurse or social worker attend clinic appointments with them as well.
So it's really not an either or, but both clinic RNs and disease and case management case manager working together
Definitely.
with the patient.
Yeah.
How do they communicate with primary care?
Well, we communicate in a number of ways. Phone, definitely, to have a conversation. But in Epic, we communicate in a number of ways in Epic. So care plans are on the problem list. And also on the problem list is our name and our direct dial number, so you can make a direct connection to whichever clinician is supporting that individual patient. We communicate through a telephone encounter information about a transition from the hospital after they've been discharged and they move to a different level of care, so you find that information there. And then we talked about face-to-face, so there might actually be that taking place every now and then.
And then I also understand that your staff also sends staff messages to
Yes.
the RN care coordinator pool. And then I think we've shared from our primary care perspective, we like to get away from staff messaging and eventually move into all telephone encounters so that the information becomes part of patient's chart. But it's a kind of a gradual process, and the goal would eventually be move away from staff messages into telephone encounters, but it might take us a while.
Right, so we're not there yet, but yeah, it would be good for us as well, so we know it's a benefit to both of us, but that's definitely something we're working towards. It's not in place right now, so yeah, staff messaging is the primary communication, other than the problem list, and then what happens with discharges.
And we also found that a lot of providers and nurses would just take the information from staff messaging and put it in the telephone encounter, so it does become a part of patient's chart, at least in the interim.
That's good.
Can you tell me a little bit about what you would like primary care staff to do? How could we assist you in care coordination, or how could we, would you like us to send you more people? Would you like us to send you less people? Can you tell us a little bit about what you'd like from us, from the primary care perspective, both from providers and nursing staff?
Okay, well, I think that, definitely in the pilot processes, there was more communication happening both ways, so it's really helpful to have communication reciprocated if we send a message that has information, may have a couple of questions. The patients are really expecting, because we talk about the fact that we're sharing the communication, so they are expecting that you're informed about what we're doing and you understand that. So it's important that we look like we're really well coordinated and connected in supporting the patient. Referring patients, definitely the pilots show that more patients have been referred, and that's great, that's fine. Generally when you make a live referral to us, then that's an identification that's probably 3 or 4 months ahead of a registry that would identify someone as having needs, so that's great. Actually, most of our identification at this point in time is done through live referrals, which is great. That's the best referral to have. That generates a higher level of engagement, because the connection and a small introduction to the support's already been teed up with the patient and family, so that, that's great.
Great. Well, thank you so much, Karen. I really appreciate you taking the time and answering some of my questions. I think that helps us all have a better understanding of what your department has to offer.
Great, thanks.